I think now we will go to question and answer session. For all 4 lectures open for questions, and we are behind the schedule, so we can allow the few questions. If there's any question, please raise hand and you can go to my microphone and questions, or can read questions.
Thank you. I thank all the speakers for the excellent lectures. My question is to Damit. This present GINA guideline emphasize more on budesonide formoterol combination because it can be used both as a preventer and as a reliever. But what is the place of fluticasone salmeterol now? Unfortunately, we don't have fluticasone formoterol combination. So, but fluticasone itself has is potency-wise is more potent than budesonide, and sometimes you have to change over your patients to fluticasone. So, what is the place of fluticasone salmeterol? That is one question, and the other is that all these budesonide formoterol combinations are 200 of budesonide, 6 of formoterol. Always the formoterol component is 6. Now, when we used to give SABA, we asked the patients to take 200 or 400 micrograms of salbutamol. So, is this 6 micrograms of formoterol, is it equipotent to salbutamol 200 or 400?
I forgot your first question actually. Yeah.
The place of
Fluticasone salmeterol. Yes. Right. So the GINA now describes 2 tracks of treatments for the stepwise management, and the track 1, the preferred what they use is formoterol, ICS formoterol combination. So the 2 combinations that we have evidence for is for budesonide formoterol and beclomethasone formoterol combination to use in this smart therapy, that is single inhaler maintenance and reliever treatment, that you give the same inhaler as the maintenance on a continuous daily dose, and the same inhaler you use as a reliever. And the inhaler that they recommend is the 206 inhaler, where you give 200 micrograms of budesonide and 6 micrograms of formoterol. So when they increase either the control or the maintenance dose or the reliever dose, you go in increasing the number of puffs. And the place for fluticasone, the question that you asked for the fluticasone salmeterol, that is a preparation that is widely available to us in our setting. Unfortunately, in the track 1, still we don't have, they don't give any provision for that. But in track 2, of course, where we use, you can use ICS LABA. ICS LABA is still in track 2 as in the maintenance, but there as the reliever you can't use the ICS LABA, but you have to go for either another ICS SABA combination, which we still don't have here, or else as a SABA reliever. So that is, I think, what you asked in the question 1, sir. Yeah.
The other question is, when you give budesonide formoterol, that 6 micrograms of formoterol.
Yes.
Or maybe if you can go on giving 2 or 3.
Yes.
So is it equipotent to what is the equipotent dose of formoterol?
Salbutamol. That I don't think so they have given in a diagram to show that what is equal salbutamol there, but still formoterol is a long-acting beta agonist, but it has a relatively short action, rapid onset of action. So I think what they say there is ICS has always, inhaled corticosteroid has always, must always be there in the, even though you use as a reliever, ICS should be there because it's a chronic inflammatory disease. So the number of formoterol, ICS formoterol or the budesonide formoterol puffs they have given that you can go up to 12 per day, but unfortunately with salbutamol, how much it is equal to, I don't think they have given.
If I is there any other questions from the audience? If I can also comment on that, on what Damit said, yes, you can go up to 12 puffs of budesonide formoterol.
Yes, sir.
Then your maintenance reliever will be the 200 dose one, not the 400.
Not the 400.
So in a patient who is on 400 budesonide formoterol, then you have to either step down to 200 or ask them to use the 206 budesonide formoterol as their second reliever.
Yes.
Another thing that, so if what Dr. Sinaratha said, those who on ICS
so many doses of formoterol,
yes.
budesonide, so that patient is not being managed properly.
Yeah, that is that we have to look at the evidence and all. And I think in our setup, cultural things are also important. With our patients, tend to restrict activity. They tend to restrict activity that will bring on asthma symptoms. So I don't know whether they'll use the MART approach and use their inhaler as appropriate, and 12 puffs is a big dose, 72 micrograms of formoterol. No? Yes. The other thing that must be emphasized is 2 LABAs can't be used together, right? Formoterol and salmeterol. So those on a fixed dose of 6 dose salmeterol fluticasone combination, your reliever would be a ICS SABA. ICS SABA, yeah. Not a LABA, not another short-acting LABA.
Yes.
No? Yeah. Any more questions from the audience? Any clarification that we needed on what's been talked so far? If I may ask Vipula a question. Of the modern occupations that we see this hairdressers and nail bar people, beauticians, coming with a lot of asthma symptoms. So acrylic is known to cause occupational asthma and the other things associated with hairdressers like the perchlorate, persulfate. So we see an epidemic of artificial nails among our female population. So can a person with asthma, can an asthmatic have artificial acrylic nails? And I think once a month you have to do your nails. Can they get sensitized? Sonali's nodding her head, yes. So once my chronology is okay, once a month. So can a person with asthmatic, can they go for acrylic nails?
Yeah, actually, so there is a well-established link between this microplastics and this hairdresser industry and this nail thing. So if there is a link, I mean, if the patient is symptomatic, if there is a kind of sensitization evidence, I think they should avoid. And this is not a, it's well-established link, microplastic and this in this hairdressers and this makeup artists. There are a lot of studies I have seen that.
I think that's what I adding what you said, that I have screened most of the occupational group for respiratory disorder, particularly the salon, and this was a beauty salon in the Kandy region. I think almost all, like sometime before, and I found actually occupational asthma is the big problem. There are so many other problems like infertility and so many things. Not only the salon people, occupation group, all these traffic officers, garment factory, and my team has screened almost all, several occupation groups, including sticks and so many. So it's a big problem, as you said, but our data was quite not enough to get to the national figures. I think that's the area we may need to do as a pulmonologist. Yeah, and then there is a pediatric asthma. I just want to know, what about this indoor pollution and the hygienic theory and things are there? In my practice, I have seen that children, they have a asthmatic predisposition from their family background, maternal, paternal. When they start the so-called preschool or kindergarten in our country, now the asthma prevalence has gone up very badly. What about your knowledge? And you may see the changes during the COVID season and now. During the COVID season, because of when everything was closed and we could not get a single exacerbation, and the asthma children are doing very well. They are asthmatic, doing well. Now that after coexisting, and even before that, how this what you are.
Yeah, actually it is proven that early sensitization, even before the preschool age, at very, very early stage, the environmental sensitization can trigger asthma in later life. And then, as you said, preschoolers, when they get exposed to multiple like organisms and all, the children who has a predisposition, but I don't think the exposure will make a viral induced wheezer an asthmatic. But children who has a predisposition, they can definitely get early development of asthma, and then even the exposure-based theory is very well established. Yeah.
Yeah, one study I conducted in the city preschool as in the village, and that's 2 cohort we have published internationally. You may have gone through that. We found that even Acinetobacter and all the bacteria living in this preschool where are close to the main cities in the Candy Lake Crown compared to the Pilimatala on that, and we found that those children had an increased high prevalence of asthma, so-called asthma, in compared to the village town. So it was a very direct research we found that. So it's a big problem in Sri Lankan. The air pollution, not only the indoor as well as this preschool and the asthma prevalence in children, and the Keith study, the Isaac study, nearly 27% or 27% was having asthmatic and allergic rhinitis. I think now the figures should be very high. If you do the real study compare that, there was another few study conducted in Colombo when I give the similar lecture sometime before I went through all the studies. Very important. Okay.
Thank you.
Just one final question from Anuradha. In the studies that you mentioned, have they looked at pheno or exhaled breath nitric oxide as a surrogate to detecting the atopic visa from the non-atopic visa?
Yeah, some of the studies, one Robinson study, they looked at the pheno, and then they have found that the pheno levels correlates with the inflammation, eosinophilic inflammation.
So
Yeah.
can you distinguish atopic visas from non-atopic visas by using pheno?
In that study, they have not they have not shown a clear correlation between the atopic and non-atopic. No, there isn't. So they just predict that it can. So they you can't clearly differentiate. Yeah.
So I think because we have reached our time schedules, on behalf of the college and our president and council, I wish to thank all the speakers formally for their excellent contributions and participating in the question and answer sessions.
To mark the end of the session, kindly request chairpersons to give away the token of appreciations to the speakers. Dr. Damit Rodrigo, please kindly request to come to the stage. Dr. Vipula Battuwarachi. Dr. Anuradha Kodipili. And Dr. Ruanti Jayasekara. I now would like to invite Dr. M.N.M. Masaima to deliver the token of appreciation to chairpersons. Sir, please remain on the stage.